When you already know the mother carries Group B strep and her waters have broken at term, the decision in front of you is not the same decision as for the woman beside her whose swab was negative. Two things change, and they change together and at once. She gets antibiotics in labor, and you move toward the birth rather than settling in to wait. Both of those acts are aimed at the same thing, the third clock from the very first lecture, the newborn's Group B strep risk, the one danger that comes due at a single moment, when the baby passes through and is born. Start with what Group B strep actually is in these women, because the mechanism is what makes it its own branch. Somewhere between 1 in 10 and 3 in 10 pregnant women carry the organism in the vagina or rectum quietly, doing themselves no harm at all. It is the newborn who is exposed, and carrying the organism is the single largest thing that puts a baby at risk of early Group B strep disease. A colonized mother is more than 25 times as likely to deliver an affected infant as a mother who is not. The path from her to the baby is physical, and it is the mechanism this whole lecture turns on. The baby meets the organism on the way out, passing through the birth canal, and the moment the membranes rupture, the sealed barrier between the vagina and the womb is gone, so the organism begins to climb upward toward the baby in the hours before birth. About half of colonized mothers pass it to the newborn. Of those newborns, with nothing done to prevent it, 1 to 2 in 100 develop early onset disease. And Group B strep is the leading cause of early onset sepsis in newborns, arriving as bloodstream infection or pneumonia, about 9 in 10 cases inside the first day of life. You might hear 1 to 2% and wonder whether that earns a branch of its own. It does, and for reasons the small fraction hides. It is the leading cause of early sepsis in a baby who was born at term and should have been well. Even at term, it kills 2 to 3 of every 100 infants it strikes, and it leaves some of the survivors of its meningitis with lasting harm. And the pool it draws from is not small, 1/10 to 1/3 of every mother you see. Rare in any one woman, common across a labor ward. And, unlike most of what frightens us in the newborn, very largely preventable. That combination is why it gets named and acted on before the induction clock ever starts. What does Group B strep and term rupture actually do when you only wait? For that, we have the cleanest evidence in the field, and it comes from inside the trial that anchors everything in term rupture of membranes. In the term PROM study, nearly 5,000 women, 4,834 to be exact, had a swab taken for Group B strep as they entered, and about 1 in 9, 10.7%, were positive. The famous headline of that trial was that neonatal infection did not differ between inducing and waiting. It sat around 2 to 3% whichever arm you looked at. But split that same cohort by who was carrying the organism, and the flat result comes apart in your hands. A colonized woman who was managed expectantly had roughly 4 times the neonatal infection risk of a woman who was not colonized, an odds ratio of about 4, with a confidence interval running from 2 up to 8.5, and a p-value below 1,000th. The organism and the waiting, compounding each other. And when you looked only at the colonized women and asked what management did to them, the split was stark. The neonatal infection rate was 2.5% when labor was induced promptly with oxytocin, and more than 8% in every other group, whether they waited or were induced with prostaglandin gel instead. The direction favored getting the baby out. Induction against expectant management, an odds ratio of about 0.3. A clear trend that landed just shy of significance at p equals 0.06. And the hardest number of all, of the 10 proven neonatal Group B strep infections in that whole cohort, not one was in a baby whose mother had been induced with oxytocin. And the single death from Group B strep was a colonized mother who had been managed expectantly. Now, the honest reader will already be reaching for 2 objections, and both of them make the teaching stronger rather than weaker. The first, That p of 0.006 is not statistical significance. The numbers in each cell are tiny. The trial let itself use a loose threshold for calling an interaction real, and the whole thing is more than 20 years old. Every word of that is true, and it means the subgroup cannot be read as a measured effect size. You cannot quote an odds ratio of 0.3 as if it were carved in stone. What the subgroup does establish, and establishes robustly, is not a number, but a shape. Colonized and waiting is the single worst cell in the entire table, and the infections and the death concentrate exactly there. Direction and location, not magnitude. That is what this evidence is for.
The second objection is the deeper one, and it reframes the whole trial. In term PROM, most of these colonized women received no antibiotics in labor at all. The swab results came back only after they had delivered, and the study came before universal screening and routine intrapartum prophylaxis were the standard of care. So what you are looking at in that fourfold risk and that concentrated death is Group B strep and term rupture managed largely unprotected. The trial is not telling you whether antibiotics work. It is showing you what the organism does to the baby when the only lever you pull is the length of the exposure. And the lever worked. Why did prompt oxytocin induction help these babies? Because inducing cleanly with oxytocin meant fewer vaginal examinations, a shorter active labor, and a shorter time from rupture to birth. And each one of those shortens the window in which the organism climbs and cuts how much of it reaches the baby. The benefit was never the drug in the bag. It was the shorter, less handled path to being born.
Which tells you exactly what modern care does that the trial could not. It adds the missing lever back. For a woman you know to be carrying Group B strep who ruptures at term, you start the antibiotics in labor and you move toward the birth. You do not wait. And the two acts are not competitors. They are the two halves of one plan because they attack the same rising exposure from opposite ends. The antibiotic suppresses and kills the organism that is climbing toward the baby. Shortening the exposure, inducing rather than waiting, reduces how long and how far it climbs in the first place. Prophylaxis is imperfect, and it is slow to take hold. And that is precisely why shortening the exposure keeps earning its place on top of it. This is why the major guidelines, asked what to do for the known carrier, converge on the same answer. Give the antibiotics and induce without delay.
There is a real divergence worth naming, and it lives at the edge of that convergence. The dominant guidelines recommend immediate induction for the known carrier. A few permit offering her a genuine choice instead. The French college treats both waiting and inducing as things you may propose, even when she is positive. And Ontario midwifery guidance offers the colonized woman a choice before 18 hours if she has no other risk factor. But notice where even the permissive positions draw their line. At 18 hours, the offer of waiting stops. That tells you the number 18 is doing quiet work in the background, and it is worth pulling into the light because it is the number most often used wrongly. If the antibiotic is going to do its job, it needs to be in the mother long enough before the birth to reach the baby and clear the birth canal. And that lead time is where the second half of the plan gets its shape. The agent is penicillin G, 5 million units into the vein to load, then 2.5 to 3 million units every 4 hours until the baby comes, with ampicillin an acceptable stand-in. The parameter that matters most is not the dose, it is the head start. Prophylaxis counts as adequate at 4 hours or more before birth, and the protection follows that interval closely. Neonatal sepsis runs at around 4 in 1,000 once the mother has had her 4 hours. At 2 to 4 hours, it is roughly 9 in 1,000, and with less than 2 hours, it climbs up towards 16 in 1,000. So 4 hours is the target you aim for, and 2 hours is already worth having because even 2 hours drops the vaginal colony count and lowers the rate of clinical sepsis in the newborn. And then the rule that keeps all of this from tangling with the rest of the labor: You never hold back a birth the baby needs in order to finish 4 hours of antibiotics. Oxytocin, breaking the waters, a cesarean that has to happen, none of them wait on the antibiotic clock. You start the penicillin as early as you possibly can, so those 4 hours accumulate while the labor is doing its own work. And when the two clocks disagree, the birth is the one that wins.
That ordering is what dissolves the apparent tension between move toward the birth and give her 4 hours of antibiotics. They only sound opposed if you imagine doing them one after the other. You do them together from the same first hour. An induction that runs its course to delivery almost always clears 4 hours comfortably. On the rare occasion it doesn't, the needed birth still comes first. The plan is ordered, not conflicted. Now back to 18 hours, because it belongs to someone else entirely. 18 hours is a number about the woman whose Group B strep status you do not know. For her, membranes open for 18 hours or more at term is one of the recognized markers that her baby is at raised risk of early Group B strep disease, sitting alongside a labor fever of 38 degrees, a birth before term, a previous baby who had the infection, and Group B strep found in her urine. Crossing 18 hours means she is given antibiotics in labor and treated as though she were positive, because you have run out of time to keep assuming she is not. It is a surveillance trigger for the unknown status woman. It is not an induction threshold, and it says nothing about the woman you already know is carrying. She was acted on in the first hour, antibiotics and induction both, long before 18 hours could mean anything for her. And the trap to step around is reading 18 hours as a cue to deliver. It is not. When to induce the unknown status woman is the ordinary induce versus wait decision from the core lecture, the one offered across the first 12 to 24 hours. Wait on the labor clock and the infection clock together. 18 hours turns on her antibiotic. It does not turn on her delivery. 2 clocks, 2 decisions, kept apart. The same discipline the whole course is built on applied to exactly this spot. 18 hours is where we chose to act on a curve that has been rising the whole time for the woman whose status we could not confirm. So when you know she carries Group B strep and her waters are broken, you are not watching a clock and deciding when it is time. You start the penicillin and you start toward the birth in the same breath, because the one danger you are racing comes due only once, at delivery. And the 18-hour number is for the woman whose status you don't know, never for her.